Hi everybody, this is Colin Blumenthal here with CardioNerds with another great collaboration with HRS TV. I'm here with Dr. Patel. We're going to be, who's from Houston Methodist. We're going to be covering a really great abstract that he has here at HRS called Pulse Field Ablation of the Mitral Isthmus, Transmurality and Autonomic Effects Validated with Vein of Marshall Recordings. It's great to sit down and talk with you, Dr. Patel.
Yeah, thank you for having me. I'm really excited to be here and talk to you about this abstract.
Absolutely. So I was personally very excited when I saw this. I've always wondered, with the ease of PFA, we are seeing a lot more posterior wall, at least anecdotally, me personally, a lot more posterior wall, a lot more lateral mitral lines, without, especially for some of these lines, chronic data on reconnection, how many of these remain blocked. So what were you hoping to accomplish with this study?
Yeah, kind of exactly what you mentioned. We had the same concerns. You know, we wanted to know, are you getting transmural when you're doing PFA? And we came up with this construct because we know that we can cannulate the vein of Marshall. It's an epicardial structure. We can record electrograms from it. And so we thought that this would be a great way to test whether, at least for the mitral line, whether you can get a transmural lesion by looking at the electrograms epicardially. And then in addition, we wanted to kind of understand the effects of PFA on the autonomic system. We know that in general PFA is felt to be nerve sparing, and we wanted to validate that hypothesis as well. And we can do that by performing high frequency stimulation for the vein of Marshall to look for a parasympathetic response, because the vein of Marshall has autonomic innervation.
Absolutely.
Yeah.
And this is, so one of my attendings at the University of Pennsylvania, Dr. Garcia, harps on this quite a lot with lateral mitral lines, that there are 4 components to a lateral mitral line. There's the endocardium up towards the vein, there's the endocardium near the annulus, there's the epicardium up towards the vein, and then there's the epicardium near the annulus. And he's a big believer in, if you want to block a lateral line, you need to be targeting all of those 4 components.
Yeah.
And the endocardium is obviously straightforward to target with any technology, but with RF, epicardium is vein of Marshall up near the vein with ethanol, and then ablation from within the CS down to get the portion down near the annulus in some patients. So it's really interesting to see that sort of thought process also play out with PFA.
Yeah, it's really a complex region, right? There's all these connections between the vein of Marshall and the atrium and the coronary sinus, between the CS and the LA, right? So and a lot of times, a lot of those connections have to be disrupted to get durable mitral block.
Yeah. So what patient population were you looking at for this study? Are these people who have paroxysmal AFib, persistent AFib? Are these people who are having mitral annular flutter? Who were you targeting?
Yeah, it was the latter. So these patients were all patients mainly who had persistent AFib, and then some who also had mitral flutter from, as either de novo or as a result of usually as a result of a prior ablation.
Yeah, as it often is.
Yeah.
Okay, so, and then in these patients, what did you find about the rate of acute block? And I know that, so I guess first to start with, how were you defining acute block? Give me a little bit of a setup of what you were doing in each one of these cases, and then how did you define block acutely? Yeah,
so let me start with kind of the experimental construct. So first we put a EP star catheter, two French octopolar catheter in the vein of Marshall, and then we would isolate the veins in the posterior wall, and then we would do pulse field ablation on the mitral isthmus. And we're monitoring the electrograms in real time.
Yeah.
And so acute block was defined as pacing from the appendage, pacing from the appendage and seeing a block pattern on the coronary sinus. So that's you can see endocardial block there, and sometimes epicardial block, but mainly endocardial block. And then we would pace from the vein of Marshall catheter and check for epicardial block, right? So, and a lot of times we would see what we call epicardial-endocardial dissociation. So the endocardium will look blocked, but the epicardium will show that you're not blocked. Okay. And now if they're both blocked, then you have acute block, and usually when that happens, you see kind of the electrograms disappear on the vein of Marshall catheter, but more importantly, they remain ablated after like 15 to 20 minutes, which was kind of our time frame to assess for reemergence of electrograms and whether we've lost block, basically.
Okay.
So that was kind of the time period that we waited.
How often did you see that dissociation? Because I feel like a lot of times when we're checking for block across a mitral line, we are mostly pacing from the appendage and looking at CS activation, or doing differential pacing and moving further away or closer to the line and looking at the transisthmus time. How often are you seeing that dissociation where you are blocked endocardially and not blocked epicardially?
We saw it about 40 to 50% of the time, like a pretty significant time. And the thing is, we never looked, we never looked for block in this fashion before, right? Because it's not like people are putting...
That's a novel thing in and of itself, honestly.
Right? And so there was a beautiful paper that came out in Circulation, Arrhythmia, and Electrophysiology where they did the same thing with RF, and they found that you can pace from the appendage, you can do differential pacing from the CS. That's going to trick you into thinking you have block when you don't. The only way to truly know is to be able to pace the vein of Marshall catheter.
And that's incredibly interesting, because I feel like that might not be routinely done in a lot of centers.
And I get why. It's cumbersome, right?
Yeah,
it takes some technical expertise, it's cumbersome, it's time, it's going to take some time.
And then you used 3 different PFA catheters during this study. Was there any difference in your rates of endocardial or complete endocardial epicardial block between the 3 systems?
Yeah, I don't know that our sample size is large enough to make meaningful comparisons. As a generalization, I can say that we felt that Farapulse and Affera had kind of equivalent rates of being able to take mitral block, whereas with Pulse Select we saw a drop off.
And that's good to know. And so another thing that I was thinking about is, we know a couple things with PFA in terms of lesion depth, ability to get transmural. We know that the better contact and the higher contact force you have generally leads to deeper lesions. There's a correlation there. And we also know that repeated applications in the same place and stacking of lesions also can lead to more deeper lesions, essentially, potentially transmural. What did you guys do? What was your workflow in terms of how many applications at each place? I know there are some differences between catheters, obviously, but how many applications at each place, as well as how you assessed contact? None of these catheters can assess contact force, obviously, but what was the workflow for those things?
Great question. So we with Farapulse especially, we would have, and Pulse, we'd have ice in the left atrium. So we're assessing contact completely ice guided. So we know we have it. And I think that's important because there was a prior study where they looked at mitral block with Farapulse, but it was kind of fluoro guided. And it's impossible to assess contact that way. So we would assess contact with ice. With Farapulse, we would do 3 lesions in each spot and overlap them by 50%, basically. And then we would we don't know what additional depth you're getting after 2 to 3 applications, right? So we stopped at 3 based on internal communications we had with the companies that would be, that there's minimal gains after that, basically.
And this is very interesting because there is some variability here too. And I'm glad to hear that it was 3 lesions, because I feel like there are some cases where people are doing 2 lesions and it's not really clear if 3 is required, or do you just need to do 3 near the annulus, and as you come back to the left inferior, 2 is fine. But so you're maximizing. That's good to know that this is a study where I'm a big believer in left atrial ice. The images for those who have not used a lot of left atrial ice are gorgeous. So you are maximizing every possibility to create a transmural lesion. 3 applications per place, excellent contact in every single lesion,
and great overlap.
Exactly. So that's the best possible scenario for PFA. And then you mentioned lesion regression, that you saw some attenuation of the signals in the epicardium that regressed. I think you briefly touched on this in terms of the waiting period, but another thing we know about PFA is that you have a central area of irreversible electroporation surrounded by an area of reversible electroporation, and the size of that sort of penumbra varies by catheter design, varies by waveform design. There are things that you can do to shrink it, which we won't get into. But what time period were you seeing the reversal of those? And were there cases where you had block acutely and after 15 minutes that had disappeared and you actually regained connection?
Absolutely. So the time frame is generally around 15 minutes we would see it. Often before, and definitely multiple cases where we had acute block, and then you wait, and then you see kind of the electrograms on the vein of Marshall catheter start to reemerge.
Yeah.
They're initially attenuated, they start to come back.
That's incredible.
And then at that point you lose your block pattern.
Yeah.
Yeah.
And that's also a very important thing with how the drive with PFA is faster cases, to do more cases per day. That's a lot of where things have shifted. And if you're just doing an empiric line or you're seeing termination of flutter acutely, you don't know, is that because the irreversible area has reached transmurally, or is that because the reversible area has reached transmurally? And if you do differential pacing or pace right when you finish and say, great, we're done, take everything out, that might not be a durable lesion
That's
set.
exactly what we would do. Differential pacing as soon as we did PFA. We would see block on the coronary sinus, on the vein of Marshall catheter, and then 15 minutes later, it's gone.
Wow.
So it's
that's very important.
And so you know that it's the irreversible effect because you see electrograms reemerge. You see that you've lost block.
Yeah.
Right.
So
it's the stunning effect.
Yeah. That's incredible. That's like very important information clinically.
Yeah.
And then just to slightly shift gears, you had mentioned autonomics with this, and you also looked at high frequency pacing from the vein of Marshall catheter. What did you find? So I guess for starters, just briefly, what are the role of autonomics and autonomic modulation in atrial fibrillation? I know that's kind of a big question. And what did you find with PFA specifically in terms of whether it affects those autonomics?
Yeah, great questions. I mean, I think the role of autonomics in AFib is a unknown to some degree question, right? We do think that there's mechanistic data to suggest that it has a role in the maintenance of atrial fibrillation, and I think that's certainly a possibility. And whether, it's a great question about whether the autonomic effects we're getting with RF, does that translate to better outcomes than what you get with PF, where you don't have that autonomic modulation? If you look at the randomized trial with the FARAPULSE catheter, the outcomes are the same, right? So hard to know.
But is it just the PVI, or is it the PVI plus autonomics?
Right. But we wanted to validate this hypothesis that pulse field ablation is nerve sparing, right? And so the vein of Marshall has mainly parasympathetic innervation to it. So we kind of capitalized on that. We would pace at high frequency prior to PFA, and you'll often see like a vagal pause. We then give PFA, and in only one patient did that vagal response go away. But then after alcohol, now the vein is completely denervated, and no patients have a vagal response.
Okay. So it really does seem like PFA is not significantly affecting the...
No, based on the current dosing and waveform regimens, it does not seem to be affecting the nerve.
Okay.
But that could also be, again, part of the reason could be just because it's also not getting transmural, right? So
that's fair.
Right.
That's fair. And you had mentioned that the goal is to obviously block the epi as well, and that the majority of these PFA lesions are not reaching all the way and eliminating the vein of Marshall signals, and that vein of Marshall ethanol injection, ethanol ablation was required for the majority of patients in this study. I think it was more than 30 of the...
27, 49% required ethanol, yes.
So that's a very high percentage. 11 patients also required ablation in the coronary sinus. One of it in isolation, and another 10 in addition to vein of Marshall alcohol ablation. How did you go about doing that? A lot of these catheters are very large footprint, especially Affera, getting these things into the CS and doing ablation in the CS with these PFA systems. What was the workflow like there?
So with Affera, we could directly cannulate the CS with it and get it in. With Pulse Select, you can get it in and then use a slider to straighten it out. And then you
narrow it.
I
was wondering how. Okay. And then basket for.
No, we did not do it with FARAPULSE.
Oh, did not do it with FARAPULSE.
No.
Okay, I was wondering if you tried to do a basket in the coronary.
I thought about it, I think it would be too, I think the electrodes would probably touch.
It would be hard to deliver energy with that close spacing of the, we've done a couple of cases with left persistent SVCs where you have
enough room
lots
to do
of
that,
room to do whatever you need to do, but with a normal size CS, tough to get some of these systems into the coronary system. And then the last thing I was interested about is you mentioned some of these patients had mitral annular flutter. A lot of these patients were fib, and this was done for persistent fib. What sort of, did you track recurrence afterwards in terms of, did patients have recurrence of their mitral annular flutter? Do you have any data on recurrence?
Yeah, unfortunately, we don't have any hard outcomes data yet. We're collecting it, so we're in the process of getting that.
Still ongoing.
Yeah, still ongoing. So,
this was a phenomenal bit of research. This was a great
you.
conversation. I really appreciate you taking the time to talk with us.
Thanks so much. Really enjoyed it.
Absolutely.
Thank you. Yeah, take care.